And a warm welcome to all the doctors who have presented here. I am Debulina from ClearNet. I would like to thank all the doctors for joining in, and it's an immense opportunity for all of us to be connected as a digital partner. So, without further delay, I would like to play a short video of ClearNet. ClearNet is India's largest live digital CME and a doctor generated medical content platform, which is exclusively free for all the medical practitioners. So, here is a short glimpse of ClearNet. Thank you so much all for your patience. Our website goes www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. Besides, we have MedWiki services, that is medical Wikipedia for doctors only. That also you can read in your leisure time. So now, without further ado, I would like to hand over the session to Dr. Varghese Thomas sir to start with our today's session. Over to you, sir.
Thank you, Ms. Debulina. Thank you for giving us this platform, and welcome Jayanti ma'am for this class. Welcome all the participants, Dinu, Abhirami, Sai Kiranmai, and Rajendra Prasad. A warm welcome to all of you, and also welcome all the other students and other faculty members who have joined. We expect Professor L. Venkatakrishnan to join sometime later. He is busy at the moment. He has not reached home yet. So we'll start off with the case. Over to Jayanti ma'am for the introduction, and after that I will upload the slides.
Yeah, so right at the beginning, thank you, VT. And I think few important messages that I would like to convey. These sessions that we are conducting is mainly not for exam purposes. It's just for you all to get a hang of certain cases, the scenarios that we come across, how to approach the case and all. Now, the important thing is the outcome of the exam should not be reflected on these classes. That's very important. It's a very important message that I would like to convey. We are here because we started this sometime in 2020 on the webinar. So we just wanted to continue this session. So whatever is being taught here has got nothing to do with the examination outcome, and none of us are to be blamed. There's no question at all if any of us are sitting as examiners that we are blamed for whatever is being discussed in the examination hall. Certain things have happened and it has affected some of the faculty members, and therefore this is a message to all. So whatever we are teaching is for you how to approach a patient that you see in your day-to-day practice. Okay, that's very important. And as Dr. Varghese said, Tuesday, or first and third Tuesday will be by the Kerala chapter. They take the initiative for presentation, and second and fourth will be from Dr. LVK and myself this side. From here on, I've decided that, it took me nearly 2 days to prepare the slides. So from here on, you have to come forward. You have to come forward with the case presentation, PowerPoint. You need not send it to us. Whoever's presenting can take up the case for discussion, and we'll be with you so that we have no idea what's happening with the patient. You can write it. You don't even need a PowerPoint. You can capture that, whatever you've written, the case sheet, and present it as a PowerPoint. Let it be a natural phenomenon. And we'll take up the discussion thereafter. So we must know that the case is being presented by Saturday of the previous week. It's very important because we are spending a lot of time preparing the slide, we're trying to get this, trying to get that. Any center, supposing it's Global Hospital Chennai, one person who takes a history should not know anything about the investigation of the case. You have to be truthful to yourself. And the other person will present the details. So every center will have at least 2 PGs. And the discussion can go across to the other side. So henceforth, I think that's what we did. Actually, in 2021, the students were just presenting whatever they had written. They were just presenting as such, and we had quick movements of the cases. So I think Dr. VT will agree to that because it takes quite some time collecting the data, collecting the slides, getting radiology, x-rays and everything. So students, please, you take charge of this. Whoever is presenting should be truthful. You have to be truthful to yourself. You have nothing to do with the final diagnosis. Present the case, let the investigations come forward, then you take up the discussion. One more person can take up the discussion along with you, and that's where we move forward. And both the cases that we're presenting today have been seen by my MD general medicine students. So they have prepared the slides, and I'm thankful to both Preeti and Vishwanath for getting us this presentation today. So over to you, Dr. VT, and I'll pitch in between.
Thank you, ma'am, for that comments. Ma'am just told me to remind all of you who are ISG national members, don't forget to vote for the national office bearers, because ISG national level also is conducting a lot of academic program. The gym program is awaited on the first week of February. It will be conducted in Hyderabad. It's a program conducted for all the DM and DNB residents in gastroenterology by the National Society. So those of you who are members, please vote. Those who are not members, please join, because the membership fees will go on increasing, and probably if you have money, you can join. And
No, the other thing is only members can attend the gym.
pardon?
Yeah, only members can attend the gym.
I don't know whether they made it that strict.
They made it mandatory that any program conducted by ISG, the students have to be members.
To be members. Yeah, it is correct that only in a closed meeting, only members will be allowed. We won't allow any others to. Okay. Now, the pattern which we have been following from our side has been the students will be asked to prepare cases in advance, and they prepare the cases, and the faculty and they will actually inform me the details. I will look at the case and then give it to a faculty, because sometimes the faculty may have different interests, like luminal hepatology and something like that. So if it is done by a faculty who has a specific interest in that particular case, the discussion would be much better, rather than giving it to a faculty who has probably lesser interest in that specialty or that subdivision of gastroenterology. And then one resident prepares and presents, and another person from the opposite Tamil Nadu side will discuss. Okay, and like that, there will be two cases, one case, depending upon that, we'll or we generally earlier we were doing in a long case, one person will present, the other person will discuss the history, second person the physical finding, third person plan out investigation, and fourth person the management aspect. That also was another method which we are following.
We'll follow whichever is coming. I mean, all these are. I mean,
so who is going to discuss first today?
Sir. Dinu Abhirami, sir.
Dinu, okay, Dinu. So, ma'am, can we start then?
You can start. You can.
Okay. Please read out the slides.
This is the first chief complaints, and then tell us what are all the things that you need to know.
Yes, 57-year-old retired mechanic presented pruritus for.
It's a male patient. Male patient.
Yes. A male patient presented with pruritus for 2 months duration, jaundice for 6 weeks duration, anorexia and weight loss for 1 month duration. So itching, it was insidious in onset, increasing in intensity.
We can just go back. Let us see what else she wants. Yeah, tell us all the details that you want.
How will you elaborate this case? Suppose this is what the patient tells you, you have to elaborate upon this. That elaboration, the quality of that elaboration is the narration of the history. And that is where you are assessed. That is where we are assessing you. Okay, so this is very important. So please tell us, how will you elaborate this? What are questions you will ask and the relevance of each of those questions?
So initial symptom was pruritus, whether it was generalized pruritus, and how was the intensity of pruritus, whether it was disturbing his regular activities, and whether it was any diurnal variation was there in the pruritus.
Is there any quantification? Is there any class grading of pruritus?
Yes, sir.
There is actually a grading, 1 to
4,
1 to 5. That's a grading. Of course, in dermatology parlance, they use it. But for us, somebody's sleep is affected. The entire night he sits up and scratches the body, means the severest form of pruritus. The other one is the present occasionally, grade 1. Okay, that doesn't bother him. He occasionally scratches, that's all. Okay, so you please just know the grade. There is a grading. Okay.
Yes, sir.
Okay, pruritus you have told. So
what
are the other questions?
What are the things that cross your mind when there's pruritus?
Whether it could be a dermatological reason for a pruritus or a systemic reason for pruritus. Dermatological reasons usually systemic reasons usually will think of obstruction and
that is a very specific cholestasis. Not obstruction. Obstruction means generally mechanical, no? So cholestasis, that will cover everything.
Yes, sir. And since
It
it is
can be hepatic, it can be non-hepatic. It can be purely skin disease.
Yes, sir.
Okay.
And his profession, no? Keep a watch on the profession, mechanic. No?
Yes,
So we did ask him exposures, no? What is his actual occupation? Is he dealing with certain things that is inhaled or something that he's coming in contact with because something new that has happened? So you have to keep a wide mind, a wide way of assessing what are the, because had you seen him say 2 weeks at that time of pruritus, most probably he'll be in the dermatology department. And 2 weeks later, when the jaundice sets in, he comes to the gastroenterology department.
Yes,
So therefore, your DDs will be wide. So maybe you've got the history of jaundice. In that context, what are the questions you'll ask in pruritus?
with the history of jaundice, I would like to know about how
No,
was
not the jaundice, the pruritus still, no? The pruritus is one that's striking. What is it striking you? What is happening? What is happening to that system? What is happening in that biliary system that is causing the pruritus?
because
So
of
look at the timeline.
Hmm.
Look at the timeline. Which occurred first?
Which has occurred first?
pruritus, and 2 weeks later,
Later,
jaundice.
2 weeks later. So what are the things you will consider like that? Pruritus begins and then jaundice. And then the other condition where jaundice occurs and then pruritus occurs later. Okay. So these are the two scenarios. So this is a scenario where pruritus has occurred first and it was followed by jaundice 2 weeks later. So a list of diseases will have to cross your mind.
Yes, sir. Mainly intrahepatic cholestasis, primary biliary cholangitis.
Don't. This is exactly what happens, no? You finish one by one. Just think, what are you discussing? You cannot go to liver and then say primary sclerosing cholangitis. No? This is exactly what happens in the exam.
Whenever you have a cholestasis, your mind must be set to decide whether it is intrahepatic or extrahepatic. So you must actually seek the points. So instead of jumping to a diagnosis, you should have told, I need more data. I need more details about the patient, without which I cannot come to a definite conclusion. Okay. So first of all, we have, because of jaundice and pruritus, we think that this is cholestatic jaundice. Okay. Now we want a lot of other points. There is only one thing which we know, that pruritus started earlier. Okay. Now something else is there in the third line. So, but we need more data to know whether it is intrahepatic, extrahepatic, whether it is really hepatic, etc.
Yes.
So tell us what all additional details you need.
Additional details.
Where do you think the pathology is when there is pruritus? What is abnormal? Then you will get the answer. At the canalicular level, what is the pathology? What happens?
Excretion
Why do you get pruritus?
Because excretion of bilirubin doesn't happen, and it gets deposited as bile acids in the today.
Can you repeat excretion of?
That's where you went wrong. Totally wrong.
Bilirubin, no.
Is it bilirubin?
What is
All the others, please
abnormal?
mute your. All the others, please mute. Kindly mute.
Bile
acids.
Bile acids.
Will get deposited in the subcutaneous spleen, causing pruritus. Bile acid excretion doesn't.
So
Where does the bile acid excretion occur? Suppose you think of a hepatocyte.
Where does it
occur?
Into the biliary canaliculae.
By which?
Biliary canaliculae. Okay.
Which system? Which export protein?
By BSCP and
BSCP, exactly. So the pathology is starting from there. So it could be hepatocytic. It can be canalicular. It may go down, right down up to the distal CBD. And the first thing that happens is the bile salt gets extruded into the sinusoid. Keep that in mind. Once you have this concept, then you can think, oh, it can be intrahepatic, it can be post-hepatic, it can be the extrahepatic biliary system. So that's the concept of the pruritus. In that context, jaundice has occurred. So when can a jaundice occur? In this context, where pruritus has come ahead, and then the jaundice.
Mainly in intrahepatic cholestasis, where
Okay,
So
I just
what is the usual natural history in an obstruction, biliary obstruction? What is the usual natural history?
sir, in biliary obstruction, most commonly they present with the jaundice associated with abdominal pain.
No,
And the
then need not
pruritus
be abdominal pain, jaundice, and soon after pruritus. No.
pruritus sets in. Pale
Okay,
colored.
because very often medium to large size duct system, the pressure increases and then jaundice occurs, bile acid increases, that happens. But in you said it is intrahepatic cholestasis. Can you tell us some conditions where there will not be no jaundice but only pruritus?
very difficult, no? It's not.
In primary biliary cholangitis and in primary sclerosing cholangitis.
They're all in the
The
biliary
drug-induced-
system. They're all in the biliary system, nothing to do with the hepatocyte. Nothing to do with the hepatocyte. Supposing the person has got a stricture in the distal CBD, what will be the first thing that will happen? Jaundice will come ahead, or pruritus will pruritus will come ahead?
Initially jaundice followed by pruritus.
Not necessarily. You can get,
That is a fairly acute jaundice, no?
yeah.
Acute obstruction.
Otherwise
If it is
it's
insidious obstruction, like a
insidious obstruction with
postoperative
first
stricture.
pruritus. First will be pruritus. Say all your cholangiocarcinomas in the distal CBD, their first will be bile retention, bile salt. They'll present as pruritus, and jaundice comes on much later. So keep that in mind. It's one possibility. What are the questions you'll ask in jaundice?
First is regarding the association, ma'am, whether the pruritus was in prior to or after the onset of jaundice.
No, we've already got post prior to.
Then associated with the pale colored stools and
What are the questions you'll ask in jaundice?
Suppose this patient present you with jaundice, what are the
yes.
questions that you will ask? That is the question.
Suppose you were to draw a graph. What are the things that can happen?
if it was associated with abdominal pain,
The first thing which you ask
Jaundice.
is, of
What
course,
happened?
apart from the duration, the onset. The onset. Well, within a short period of onset of whatever symptoms the patient had, patient has got jaundice. So that means it is fairly acute. Or whether it's an insidious, gradually, slightly progressive, or many weeks. So onset. Second one is prodromal symptoms. Third is abdominal pain.
abdominal pain.
Fourth is presence of cholestatic symptoms and associated phenomena of cholestasis. Okay. Then look for pictures of cholangitis like Chills Riger. Okay. Prior history of manipulation of the biliary tree. Prior history of disease of the biliary tree. Prior biliary surgery. All those things are important. Then history of toxic agents like alcohol, drugs, and various other things. Okay, then susceptibility factor, risk factors, whether the person has got a community-acquired viral hepatitis, whether there is a social clustering, community clustering, whether the person has traveled to an area where there is increased viral hepatitis. See, so many questions come one after other. Okay, so this is just to know the type of disease and what form of disease, whether it is simple hepatocellular or a cholestatic or a combination.
Yes.
Yeah.
Is that clear?
Yes, sir.
So what I usually say is, just draw a graph, x-axis and y-axis. And once you draw the graph, you'll have one onset, as Sir said, and then you'll have a rising phase, and then you'll have a cholestatic phase. That cholestatic phase may be continuous, or there can be a waxing and waning. It may be continuous, or there may be a response, and the patient may be resolving. That graph will explain everything. That's the first thing to describe for the jaundice. Once you've got this, then comes all the precipitating factors. What are the possibilities? What is it? So first is just that, just have a graph then. And then you have this, then you can just draw the graph associated with pain, associated with fever with chills. Is there loss of weight, loss of appetite? And then comes the etiology. You got that?
Yes.
Now come to the last, anorexia and weight loss. Any significance of that in this?
Yes, ma'am. Associated anorexia and weight loss indicates most likely a malignant.
Not necessarily, it's a chronic process. No?
Chronic process.
Most of the time, some people, they say, don't take salt, don't take this, don't take that. And they'll be given bland one curd rice, or they'll have just one roti, nothing will be there. So anorexia weight loss can just be a consequence of the disease process. And then it's a chronic disease. Why neoplastic? Can it be tuberculosis? Why are you considering neoplastic? Can it be tuberculosis? Chronic disease, any chronic disease will have anorexia and weight loss, no? And already you have pruritus and there's anorexia and weight loss. You got it?
Yes, ma'am.
Yeah, so very important. The other important, I think many have joined by now. I think one important thing that has happened during this particular exam, this particular session is most of the candidates have gone to tertiary referral centers. I think this is something that I must tell. I forgot to mention that. So they're all cases with a diagnosis. Okay? They're all known cases. So be prepared for that. This is something out of the box that happened this time. Almost every corporate hospital had all cases which was completely worked up, and cases came only for the sake of the examination. So there will not be much of discussion on the history. It goes straight as, say, for example, I just want to, I think many would have joined by now, known case of disease. How will you manage this patient? What will you do next? So the takeoff is totally different. The takeoff of the discussion is totally different. What we're discussing here is a kindergarten type of approach to a case in an outpatient clinic. Okay, we can move on to the next slide. Very important. Yeah.
The itching was insidious in onset, increasing in intensity. Jaundice was also insidious in onset, waxing and waning in intensity.
So what he found was sometimes the yellowness was high, sometimes it was low, but he could not tell. Sometimes he said itching was also less, sometimes itching was also more. So what else would you like to ask? And there's a weight loss of 6 kilos over 1 month. There's no prodromal symptoms prior to the onset of jaundice. There's no fever, no abdominal pain, no abdominal distension, leg swelling, GIB, or any other pain. Now, can you interpret what is happening to the patient? What is this waxing and waning due to?
Waxing and waning could be due to intermittent obstruction, which is getting relieved in between.
Which are the conditions which produce intermittent jaundice, cholestatic type?
So extrahepatic causes include choledocholithiasis causing
Okay, great. Choledocholithiasis. Any other condition?
periampullary malignancies.
So in a short history, you may not get the classical waxing and waning because it will take time for the periampullary tumor to ulcerate and relieve the obstruction. But in a slightly longer history, the classical waxing and waning is there. But here it is actually present. Waxing and waning is there. Okay. Can you tell the importance of the last line with the abdominal distension, leg swelling, GI bleed, all those things? Do you think it is relevant in this case?
Yes, sir. Because,
why it is relevant?
The onset of symptoms is almost around 2 years. I would consider possibility of secondary biliary cirrhosis or underlying cirrhosis presenting as jaundice.
Duration of illness is not 2 years, no, 2 months only, no?
2 months.
Okay, no. Now, what are those abdominal distension, leg swelling, GI bleeding? So, what does the person who is putting the question, what do they want to sort of rule out?
Decompensation of
so do you think it is relevant in this case?
Yes, sir.
Why? How it become relevant?
Whether patient is going in for secondary biliary cirrhosis and going for decompensation.
No, see, any cirrhosis for that matter, at one point of time may have an additional insult and they may have more jaundice. Okay, so at that point of time, the basic cirrhosis may decompensate. For example, somebody has cirrhosis liver, on top of it there is viral hepatitis E or viral hepatitis B. So you will have the person will have some features of acute hepatitis, but some features of decompensation also will happen, like ACLF, no?
Yes, sir.
So that means there's a background liver disease on top of which there is another problem. Okay, because the patient can present in any way. Okay, the patient can present in any way. Okay.
The other thing that has been taught to us when we were students was, Professor Madan Gopal would say, in hilar cholangiocarcinoma, what you would say, if the tumor is quite large, it engulfs the lymphatics around the hilum. And that can cause exudation of lymph into the ascites. So you'll always say, in a patient with obstructive jaundice, if there is ascites, he would be able to make a clinical diagnosis of hilar cholangiocarcinoma. He will say there are only two DDs. One is subacute hepatic failure, which is failure occurring within 3 months. And the second, he would say hilar cholangiocarcinoma, and he'll be dot on right on that issue. And we used to ask him, how does he say that? He would say that the lymphatics that are coursing along the CBD, this is all by personal experience that they're talking. You cannot mention all this in the exam. What answer you have to give is what Dr. Vitti mentioned. You understood? Yeah, but just remember, so in a clinical situation, you see in the outpatient clinic, you see this, hilar cholangiocarcinoma should keep on your mind, because I have seen this. Someone has taught me this, and it is logical that the lymphatics get obstructed around the hilum, and the chance of lymph exudation into the peritoneal cavity is likely. Okay, but underlying liver disease is the most important thing that you have to keep in mind. All right, let's just move forward. Next slide.
Past history of diabetes mellitus for the past 15 years. He was changed to insulin for the past 3 years. History of RTA 40 years ago. He required surgery and blood transfusion. No history of any drug allergies. Personal history. He consumes alcohol, abstinent for the past 6 years. Approximately past history 84 grams of alcohol per week for 30 years.
So now you have no background.
Background.
So there is some background of alcoholism. Nothing prevents him from not having a severe fibrosis, and now it could have been compensated. It's a significant quantity that he's taken for 30 years and then stopped for 6 years.
Yes,
got that. So I think at the age of 15 or 17, he started drinking, and then that's what happened. Then he's a smoker. There are no tattoos. Okay, so the significance is, now tell, what's the significance of the road traffic accident and this particular case? Why is it? Actually, this history was not forthcoming, but on examination, we found certain things. And then we asked what happened. That's how you have to, you cannot say that on examination, I saw this, but the patient didn't say anything. On examination, he found some graft and all, skin graft and all. Then we asked him what it is. Then he came out with this information. Then we asked him to receive that translation, and then he came out with this. Now, can you explain this and this present case context, in this context?
So, road traffic.
With an anorexia, weight loss, jaundice, and this.
Road traffic accident, 40 years, required surgery and blood transfusion. Two points are there.
So history of blood transfusion, any contraction of viral hepatitis in the past, and history of previous surgeries.
Don't say viral hepatitis, chronic heterotropic virus infections, no?
Yes, ma'am.
That's how you use. That's the
Which
term
are the infections which come through transfusion and surgery?
So, to transfusions, mainly hepatitis B and hepatitis C, and surgery.
Do you know since when blood bank started strict screening for hepatitis B and C?
1990s.
Around 2000, plus or minus 2 years. Okay, so people who had transfused before that would not have hepatitis C tested. Okay, B might have tested from 1990 onwards, but C testing routinely started only after 2000. So the last 22 years, only perhaps people started getting screen blood. Even if the patient is given screen blood, and is it possible that they can develop hepatitis? They can contract hepatitis B or C?
Yes, sir. When the donor was in the window period, then.
So, is there any test by which you can find out that?
Anti-HBC core antibody.
Okay. So what are the different methods by which you can, that is hepatitis B for hepatitis C? What do they do for HIV? No, the blood bank.
Western.
Nucleic acid testing. Okay, that is what they. Okay.
Yes, sir.
Okay, so the Hep B and Hep C risk.
Yes.
Hmm?
Yes, sir.
That will have to be, therefore, that will have to be kept in mind.
Yes, sir.
And the history of ethanol. He has stopped taking for the last 6 years. So that means, will there be a risk now of alcoholic liver disease?
Yes, sir. Previous history itself is
And
significant.
diabetes, and diabetes.
Yes,
There's an
sir.
apple D, there's an
Yeah,
apple D,
diabetes.
there's a
So multiple
diabetes.
risk
You have to
factors.
underline all this. So
suppose
100% you
he-
will have fibrosis.
Yes.
Any day.
So he has stopped drinking for the last 6 years. So technically, can he be having alcoholic liver disease now?
Sir, previous fibrosis because
Yeah, he could have had cirrhosis, and cirrhosis can remain in the compensated stage. He stopped drinking, no?
Yes,
Among the various forms of alcoholic liver disease, which one you will not consider? There are different ways of presentation of alcoholic liver disease. What are those? Just name.
alcoholic hepatitis, sir.
Okay.
Alcoholic fatty liver disease.
Cirrhosis.
First is
Yeah.
alcoholic fatty liver disease.
So can this be alcoholic hepatitis?
No, sir, because recent
So that is what I want. Yes, a person who has not taken alcohol for more than 90 days, we won't consider it. Okay.
yes, yes, sir.
So that part, that timeline has to be very clear.
Yes, sir.
Okay.
So the same question, if it is asked, why sir asked, no, why was abdominal distension and swelling? Now you can say the person could be having underlying chronic liver disease. He would have developed a HCC. Now can you explain that? You can explain, no? You can explain an HCC. You can explain the cholangiocarcinoma. You can explain the risk of cholangiocarcinoma, pruritus, jaundice, anorexia, weight loss. One. So therefore, with this, right now, you have to already start filtering out what is your differential diagnosis, and the risk for HCC is likely to be a combination of B virus, C virus. Some of them are direct carcinogens. This all you should know: what is co-carcinogen, what is pro-carcinogen, and what's a carcinogen. This definition is asked. So HBV is a carcinogen, whereas HCV goes through cirrhosis. Alcohol also goes through cirrhosis. They're all pro-carcinogens. Aflatoxin is again a carcinogen. So you must know some of these. Anyway, so therefore he's at a risk for, now you have at least one differential coming out with all the risk factors. Okay.
Yes,
Okay, we move on. Next slide. So now I can take up the exam. So, okay, just close down. Let's go back. Now tell us what will be your syndromic diagnosis. Syndromic diagnosis and differentials at this stage.
Syndromic diagnosis at this point would be
anything else you want to know, you ask me, but nothing else was contributory. Okay, most of it, this was sufficient for us to make a diagnosis. So now tell, what's your syndromic?
syndromic diagnosis would be cholestatic jaundice, probably of so at this stage I would consider both intrahepatic and extrahepatic causes.
No, in this not this this not the way to answer. You have to say that I would discuss what is your bet. Your bet is intrahepatic or extrahepatic. Take that first and then consider what is your bet in this patient. Like to be extrahepatic or intrahepatic. That's your bet. In your mind, you've already got the columns. You know, you've got the column in your mind. What are the points for and against?
This patient, I would consider most commonly an intrahepatic cause.
First, as intrahepatic.
Intrahepatic.
What are the points for intrahepatic?
Intrahepatic pruritus was followed by jaundice, and there is no.
Is that more common in intrahepatic or extrahepatic?
Intrahepatic.
And other thing that happened in this exam, you know, I'm just telling that's what happened. So candidate finished first case, also finished second case, third case, and he's sitting without understanding what questions can be asked. What you should sit and do outside when you're sitting in the examination hall after you're finished. Think what are the possibilities, have a table. If they ask me, these are the points for, these are the points against. And that is how, so it's easy for you to answer as the examiner asks. Now you tell me, why did you think? So you think intrahepatic more than extrahepatic. Rajendra, what do you think?
Yes, ma'am. I'm thinking extrahepatic.
So you want extrahepatic. Sai?
I would like to go for
Intrahepatic.
Intrahepatic. So we have 2 against 1. Okay.
So Rajendra, what are your points for making a diagnosis extrahepatic?
One is cholestatic picture. Second is surgery.
Picture will be there for both. So that is not a
History of surgery is there, sir, but there is no clear cut whether surgery is where it was done. Maybe abdominal surgery.
No.
No. Okay, that we have not mentioned any biliary surgery. So we don't. It was accident and some surgery on the limbs.
Limbs.
Sir, and
not biliary surgery.
Yes, sir. And history of
Are there
vaccine and
clinical point aids to diagnose extrahepatic?
No, Rajendra, just imagine 40 years back, biliary surgery and coming to you with jaundice now. No? So just be careful when you're answering that question.
And history of waxing and waning type of jaundice. So I would like to consider an extrahepatic.
Any other possibility? Any other points for?
Okay, Sai, what are your points in favor of your diagnosis?
Because pruritus is followed by jaundice, and then patient is having anorexia and weight loss, which I feel.
So because of anorexia and weight loss, you think it is intrahepatic. So what is in your mind? What are the situations where you get anorexia and weight loss in an intrahepatic?
So now tell you differentials for intrahepatic.
If you say that it is intrahepatic and then you have to give us the explanation why there is anorexia and weight loss. You are telling it is in favor. So how does it favor the diagnosis of intrahepatic?
What are the causes? Just in the causes.
Or what are the causes you think which is causing anorexia and weight loss and intrahepatic cholestasis in this patient?
Because patient already having a risk factors for an underlying chronic liver disease.
No more discussion. Just tell the causes. 1, 2, 3, 4.
Cholangiocarcinoma on top of a CLD.
Cholangiocarcinoma
on underlying CLD.
Cholangiocarcinoma, this is intrahepatic.
Intrahepatic cholangio.
Okay. Then you'll have to tell the points for and against. Again, then 1 cholangiocarcinoma. Number 2.
Benign causes of primary biliary cholangitis.
Primary biliary cholangitis, usually the history of pruritus is for years, followed by jaundice, no? So this is a short gap of 2 weeks. What else? Okay.
What else?
You said about intrahepatic cholangiocarcinoma, primary biliary cholangitis. What are the other DDs?
Dinu?
Primary sclerosing
That she's already said. Any other? What are the causes of intrahepatic cholestatic jaundice? Just list it out. Number 1.
Number 1, it can be drugs.
First, it can be drugs. Exactly. So number 1 is drugs. Okay. No, we won't take we'll just say number 1 drugs. Number 2.
Cholestatic phase of viral hepatitis.
Which viral hepatitis?
Hepatitis C virus.
C does not cause.
Have you ever seen acute viral hepatitis C?
C.
If you diagnose hepatitis C as a cause of acute viral hepatitis, I think it will be very difficult for us examiners to help you.
Don't blame the examiners. You people are very
don't tempt us to do some drastic things. But acute hepatitis C is a very theoretical thing. Acute hepatitis C can occur, but it doesn't present clinically with icterus. It's extremely rare to happen.
Which are the viral hepatitis?
Hepatitis A can cause cholestatic.
A, 59-year-old.
Why? What is the relevance of age and hepatitis A? Which age is the hepatitis A is common?
Younger age group, sir.
Younger age group. Why in younger age group?
Because it is mostly spread by fecal-oral contamination.
Okay, so elderly people will not get contaminated fecal-orally. Both are the father and the son both are taking water from the same pond, same well. Why the father is not getting? Why the son is getting or the daughter is getting?
Or the grandchild is getting.
Grandchild also getting.
Please
because they could have been exposed. They could have been exposed much earlier, and they could be having anictry hepatitis. Even there may not be a history of jaundice. There may be or may not be. Okay, so they would have become immune by the time they become adults. Okay, that is the reason we don't consider. We won't say, for example, somebody coming from Europe or USA coming to India at the age of 60 or 80, still they can develop because they are not immune. But in India, in our situation, most of us would have been exposed. Most of us would have been exposed during our adolescent and early adulthood itself, and we would have got immune. So we don't develop hepatitis A. What about E?
I'll just one more reference to A. The group of adults you get in A is children who have just joined college from the school. Up to school, we're all fed from home. We take food from home. Everything is sterile. Everything is hygienic. Moment you leave and you go to the college, you start eating junk food and food from outside. Usually it is at 20, 21, 22 years. Okay, those are if you get an adult with acute viral hepatitis A, they'll all be 59, 60s. They'll all be this 20 to 25 years old. Many of them are getting vaccinated also against A. So I think you have to be aware of that. All right.
Yeah, this is very common. This is very common. What ma'am said is very common.
Yeah.
People who are protected by their parents up to +2 suddenly get admission in some engineering, medical college elsewhere in another state, etc. They'll be living in hostels, and very often the water source. I know of one professional college where one of my relatives developed almost all possible enteric infection, including typhoid, acute dysentery, hepatitis, almost everything, because the water source was bad, and they developed, and they are susceptible. Okay. So now young adults are susceptible. Young adults are susceptible because they are slightly affluent people. Everything will be taken care of until +2. After that, they will be released. So they will go and eat whatever things want.
And adult A will behave just like this. That 21 will prolonged jaundice, prolonged cholestasis. They can even develop ascites. Sometimes you may have to even give steroid to allow them to come back. It takes about 4 to 6 months Please read about adult A HIV. HIV in adults. Please read about that. What is the other virus? Come on, fast. If not A, what is the other virus?
Fecal orally transmitted virus.
Which is the other one?
The next is
hepatitis E.
E. So E, what are the three modes of transmission? I mean, can it be, so you call it sporadic, endemic, and epidemic. You can get 3 types. So you must know the epidemics that have taken place in India on E. You must know the sporadic, and Kerala and all are endemic. Get these clusters of cases. So sporadic, endemic, and epidemic. So read about HIV. So second possibility is E, can be reactivation of B, right? In this patient, DILI is one. And then, of course, we have the alcohol. Right now, no alcohol, so that comes out. So you have intrahepatic cholestasis, viral hepatitis, DILI. And number 3, any other possibility? Third, NAFLD, NASH, less likely. Normally the HCC. HCC as a complication of this multiple complications. So to me, the differentials will just be this. I'll be able to explain all the factors in this case, okay? When you come to extrahepatic, so these points favor me for intrahepatic. What are the points for extrahepatic? Which is pruritus that is followed by jaundice, progressively increasing, waxing and waning is there. There is anorexia and weight loss. So ampullary carcinoma will come as one of the differentials. Unlikely to be cholelithiasis. There's no cholangitis. There's no pain. There is loss of weight and appetite, again moving towards a neoplastic lesion. But the points for against extrahepatic is plus minus. There are a few points for and few points against. Okay. So these will be a discussion will hang around here. Okay. Can we move on? Now, don't move on. What are the investigations you want? Yes, Rajendra.
No, physical examination specifically, what all things they have to look for.
Physical examination.
Physical examination specific, apart from telling jaundice, this, that, and all. When you have a person with a jaundice with cholestasis, your eye should go and look for certain things. You have to actively look for it or exclude it, because that is what the examiners expect you. Not a simple A to Z, pet to foot, everything negative, no, like that. Okay. Because we want to know that you have you have applied some intelligence in doing that physical examination, not a cursory routine physical examination.
Rajendra?
Yes, ma'am. So I look for nails, any shining nails, and then.
First is jaundice, no? Yes. Start with the eyes.
Confirm jaundice. Okay.
Can you get cholestatic veins?
Deep yellow color jaundice.
Yeah, you can get what's called as cholestatic rings. This question is also asked. So it will appear almost like a Wilson ring. Okay, KF ring. So you can get cholestatic ring. Vitamin D deficiency, you may get findings. Vitamin A deficiency, you may get some findings in the eyes, which is already 2 months history. So look for all the eye signs. Now, then more oral cavity, anything you'd like to look for? Patient is diabetic, you look for thrush. Okay. Now move on from the neck downwards. What are the important things that you look for in this patient? Move down. Neck. What are the things you look for in the neck?
Anything in the neck? Examination on neck, is it relevant? Sai, is it a routine examination or is it relevant?
They're all muted, huh?
No, they are not muted. Only mild mental
This is a simple question.
Okay. Is there lymph nodes? What is the relevance of lymph node? Enlarged lymph nodes on both sides.
Lymph nodes, come on.
Isolated lymph node, left supraclavicular.
Can the whole the case that you're discussing
lymph
be a case of
multiple
lymphoma?
groups which are present. That its relevance is different, no?
The case may be a case of lymphoma or tuberculosis, no?
It
So
can be a case. It can be a case of. Last week I had a case from AIG.
Yeah.
It was a case of obstructive jaundice due to lymph node enlargement.
Exactly. So lymph nodes very important. You have to look at the left supraclavicular lymph nodes, iris nodes. Then in the hands, what are you looking for? The hands, shiny nails, resorption of the nail bed. You can get clubbing in long-standing cases. So these are some of the things that you look at. Scratch marks.
Near the elbow, what will you look for?
Scratch marks.
Elbow region, what will you look for on the outer aspect?
Scratch marks.
Scratch can be everywhere, but specifically in a long-standing cholestasis, you should look for xanthomas. Xanthomas are near the elbows and on the knees. Okay. Xanthomas.
And what else? There's scratch marks all over. Hyperpigmentation. Supposing it's a case of PSC, long-standing secondary biliary cirrhosis, you get hyperpigmentation of the skin. And you may get some bleeding patches, especially if there's vitamin K deficiency. In the lower limbs, nothing much. There's nothing much in the lower limb. Okay, so that's on exam. Now, rest of the examination, abdomen, what are you looking for?
Abdomen, inspection. No, we thought of liver disease, so you should look for abdominal distension, dilated veins, front and back, etc. Anything else, which is to be detected on inspection.
Any systematic of knowledge.
Which one? Yes.
Visible gallbladder, sir.
Yes, very good.
Yes, that is very important, and also they will ask you to show it to them. How did you inspect? So where do you go? How do you inspect visible gallbladder?
Where do you stand?
Where do you stand?
From
right
the
side,
foot,
left side,
foot end.
foot end. Okay. So if you are asked to go and check for it, they are actually testing your knowledge in physical examination. Okay. Heaven's sake, don't stand near the bedside on the right side and examine. You have to go to the foot and examine. You may see it, you may not see it, but the action should be correct. Okay.
Okay.
And palpation, what are the things you look for? Palpation.
Any palpable mass in the epigastrium or right hypochondrium?
Okay, first is hepatomegaly, then gallbladder palpability, any other mass which is palpable, any other mass in the abdomen, anywhere in the abdomen, spleen. Look for ascites.
Would you look for spleen in this patient? Why? Should you spend time? Should we spend time looking for the spleen in this patient? Can you get splenic enlargement in this patient with obstructive jaundice? Can you get splenic vein thrombosis?
Yes.
Supposing you have hilar cholangiocarcinoma and you have portovein thrombosis, yeah?
Yes, ma'am.
You can get a stage 4 disease. See, this is what happens, no? So then what I would ask is, now tell me what's the relationship between the portal vein, the CBD, and the hepatic artery. This is how the question starts, just to know whether you have the basics sound and strong. So the bile duct lies in front of the portal vein. So there's a cholangiocarcinoma, it will infiltrate the portal vein and you can get secondary portal hypertension due to portal vein thrombosis. Are you understanding? You must know the basic anatomy, how the portal vein is in relationship to the CVD and the hepatic artery.
No, if it is a hilar lesion, that question will be definitely asked because operability depends upon vascular
Everything
integrity. So the anatomy of the portal vein, the bile duct, and the hepatic artery will be asked at the portal hepatitis, and you must be thorough about it. Absolutely thorough.
Absolutely.
If you are not so sure, just ask your surgical colleague because in their textbook describe in a much better way because that will give us give them a clarity regarding surgical operability. So ask your surgical colleagues; they'll be able to help you out in this. Okay. Your
What are
text
the
may not show it.
what are the cutaneous markers you look for in this patient? What are the other? We said obstructive jaundice, waxing and waning. What are the other physical findings you look for? Sister Mary Joseph nodule, Trousier sign. Are we asking you too many questions? Then we can hold on. If you feel that we're asking you too many questions, just let us know. We're just asking you simple questions. Physical examination. What are the things that you look for in this patient? So nodes are important. Trousier sign is important. Trousier sign is important. Sister Mary Joseph nodule is important. They're all relevant because we have not yet opened up as to what the examination finding is. But when you examine the case with that concept of this is a history, these are the things that you would look for on physical examination. Okay. Have you all of you are muted? I do not know whether you're understanding what we're talking or are you finding it difficult to understand? Let us know. No problem.
No. What we are discussing is only what is given in Bailey and Lowe and Harrison. Actually, we are not even discussing things which are given in Schlesinger because we have not gone beyond the approach to this issue. There's nothing, and there is no hard theory and all we are discussing. It's just a clinical medicine. Remember, what we are testing is your clinical knowledge at MBBS level even. Physical examination
Just
and all is just MBBS level. General examination and only slightly sort of detailed version. Okay. Even examination of the abdomen, the method, the looking at gallbladder from the foot and also MBBS knowledge. Okay. Nothing, no DM knowledge and all. That is why when you make a wrong physical approach to the patient or when your findings are wrong, the examiners will get cut off because physical findings will have to be correct. No, you are at a second level PG. It is around 12 years of medical training. And at that point of time, you cannot make mistakes on physical examination. That's why when there is a mistake, gross mistake in physical examination, it will be difficult to wriggle out of that trap. Okay. So you must be very careful about physical examination. And this you practice day in and day out. On the day of examination, you cannot practice something new. Okay, now with the availability of all CT and MRI and all, practically no one touches the abdomen. Ma'am was just telling about the new culture. But if you're a patient, you have to examine the patient as you are an MBBS student. Okay, and learn the art of physical examination, make it thorough. Shall we move to the next slide?
Examination. Yeah.
Rajendra, can you just do that?
Yes, sir.
And let me see.
Next slide. Yeah.
On examination, patient is conscious, oriented, and cooperative. Vitals are within normal limits. Patient had mild icterus. Leukonychia is present with shiny nails. No cutaneous markers of internal malignancy. No pallor, clubbing, pedal edema, or lymphadenopathy. Lower extremities, left lower limb skin graft present. Multiple scars present. Right lower limb, multiple scars present on foot. ECOG performance status is 0. Systemic examination, cardiovascular system, first heart sound and second.
That's okay. Cardiovascular, respiratory, CNS normal. Next slide. Next slide. Just go straight to the palpation. Liver span is 10 centimeters. Spleen is not palpable. Drop space is tympanic. So at the end of examination, you're still left with your differentials, what you saw in the beginning. Now, can you shortlist the differentials and tell now what are the possibilities? Now you have to give your final diagnosis after examination. So what's your final diagnosis? Ravindra, Rajendra.
Examination has not given you much clues. So back to square one. So tell us your DD according to priority, first 2, 3, not a big list.
So it is a case of cholestatic jaundice for evaluation. Extrahepatic, I would give probably extrahepatic than intrahepatic. So my differential diagnosis is periembolic carcinoma. Second, CA head of the pancreas. Third, I will think viral hepatitis.
No,
Primary.
So you cannot have a list of diagnoses which are in North Pole and South Pole. It must be sort of together. If you consider extrahepatic, benign extrahepatic malignant, suddenly you cannot jump and make intrahepatic, because then that means you are not logically thinking. See, we have to take the diagnosis with the maximum points, and then second one will be the lesser point, third. And we don't want you to tell us everything and with totally unlikely things also. So you said periambulary. You have to define periambulary.
Yes, sir.
That's all.
First one.
If
Second,
you have another diagnosis, you have to defend it.
Yes.
So you have periambulary. Second one was
What are the points for periambulary?
periambulary.
One is age, pruritus followed by jaundice, waxing waning type of jaundice. Second, recent worsening of diabetes. Recent worsening of diabetes.
What is not palpable?
Gallbladder is not palpable.
You expect it to be palpable or not palpable?
Usually in
Expected to be palpable. Yes,
the hepatomegaly will be a little more significant. That's another thing. Usually extrahepatic, because the bile stasis, there will be some degree of hepatomegaly. That is one of the differentiation. Significant hepatomegaly is more in favor of an extrahepatic. That biliary mechanical obstruction. Okay, obstruction can be still at the hilum. Mechanical obstruction. Here, the liver span is only 10 centimeters. That's a little unusual for an extrahepatic biliary obstruction.
Exactly. Extrahepatic biliary obstruction, we expect a much larger liver. Jaundice is also mild. There's hardly any jaundice right now. He's only got a hepatomegaly. History says waxing and waning, pruritus. Maybe it's just settling. The whole thing is settling. So extrahepatic biliary obstruction will not come as a DD after this particular examination. Do you agree to that? Any doubts you have, please ask. You can just ask. Carcinoma head of pancreas will not come as a DD.
We'll ask all the people. Do you know?
Yeah.
What do you think? Endohepatic or extrahepatic? Again.
Based on this examination finding.
Still, I would consider intrahepatic.
And what is your diagnosis?
Now in intrahepatic, what's your differentials?
First would be a viral hepatitis.
Viral hepatitis.
Viral hepatitis. Which one?
Which one? Again, we've already discussed, no?
Yes, we have mentioned everything, no? A, E, B, etc. So which one you want to consider?
More likely?
More likely E and B, sir.
Just now we said A unlikely in this age. No? So
A unlikely, prodrome was totally missing. That's another thing against E.
No prodrome.
No prodrome.
So E and
no prodrome. Both A and E usually will have classic prodromal symptoms, fever, anorexia, nausea, all those things which last for a couple of days. No, and hepatitis B, acute attack, they may have myalgia and feverishness, but reactivation of a chronic hepatitis may not have much of a prodrome. Okay.
Reactivation of hepatitis B or a C.
Reactivation of a background hepatitis B can be with cholestasis also. So among hepatitis, probably B with reactivation may be possible. Okay. What about DILI?
Also possible. 20% you may not get a history at all. You may not get a history at all.
The
so
person, suppose the person vouches and says that I have not taken any drugs in the last 90 days. Still, can it be DILI? Mostly the person may not remember exactly what all drugs they have taken, even for silly things. Okay. Second, many persons in India go for traditional treatment to traditional healers, and they tell go and pluck that herb from your backyard and make it into decoction and take it. And
Especially,
those things and all they will not consider as medicine at all. It's a sort of general knowledge in the village. So they will not tell it. They will not even consider it as a medicine. And
something
so,
that Giloy, Giloy, no, what they said, someone.
Yes.
Yeah.
pardon?
Herbal, Giloy. Yeah, they're all leaves that are seen in your garden, but it causes acute liver failure. In
And
COVID,
third one is slightly sophisticated people are now fond of various food items, food supplements, and other things, green tea and all those things they order online and are taking. One of my patients actually took a special fruit diet for health and developed a classical intrahepatic cholestasis after taking that. Okay. Another patient was investigated for abnormalities, investigated left and right, could not find anything. And for some reason, the patient improved, we were about to discharge. And then the doctor suddenly asked, can my mother continue that green tea which was taking, which she has started taking 2-3 months earlier? Suddenly we realized that most probably that was the cause which we actually overlooked. Green tea and all people will not say. Green tea is basically some sort of a decoction.
yeah,
Okay,
exactly.
so
So unknown. So despite your best history, 20%, Delhi will come as one of the differentials. Okay, differentials will be chronic hepatitis B reactivation. It could be an E. However, prodromal symptoms are not there. Then they will ask you what percentage. So less than 20% may not have prodromal symptoms. That is one. Delhi will come as a DD, and HCC. HCC will come as a DD. Loss of weight, loss of appetite is there. There is this thing.
anorexia and weight loss is
Weight
there.
loss is there.
Weight loss is there. That has to be explained.
It has to be. So it can be nodes at the quota that's actually causing the jaundice. Okay. Now, it can be. So
do you have anything else to add, Sai Kiranmai?
Any doubts you have?
Do you have anything else other than these thoughts?
Even PBC frequently presents with a long history, why can't we consider PBC in this patient?
Yeah, if there is a history of pruritus is very long, we can easily consider that the gap between onset of pruritus and jaundice was 2 weeks here. But it is usually months and years in PBC. That's the difference. Okay. PBC person may present with pruritus for months or years and then come. Of course, sometimes it may come faster, but the classic history is like that. A typical thing can happen and then baffle all of us, but we go by the classical clinical knowledge. Okay, now can we ask the candidates how to investigate? Sai, how will you investigate this case?
Oh, no, wait. Yeah.
We'll ask them. We'll ask her how to investigate and then
show them.
How will you investigate? First.
I would like to get his baseline investigations first, coming to complete blood count to look for anemia because he is having anorexia and weight loss for past 1 month. And to look for platelet count if to rule out any underlying chronic liver disease.
Right.
And coming to liver functions, because he is having a cholestatic pattern of symptoms. I would like to look for what is his ALP levels and transaminases and albumin levels in view of low nutrition.
So what do you expect? What do you expect the LFT to be in this patient?
Can you predict the LFT in this patient?
Predominant alkaline phosphatase elevation.
What will be the bilirubin like?
Bilirubin is mild decrease, so it is definitely more than 3 milligram per deciliter.
More than 3. Okay. And what about the albumin?
Albumin, I expect it to be low, sir. Even
low,
patient has.
Is there any clinical clue to be for this to be low?
Clinical clue of edema is
no
not
ascites edema, no?
But because anorexia, weight loss, so some amount
maybe
of
if at all it may be mild due to low food intake, but we don't expect it to be below 3. There's no ascites, no edema.
Next investigation.
What is the specific investigation we will do?
Because we are suspecting a viral etiology as one of the differential diagnosis, I would like to look for viral markers of hepatitis B.
Okay, next.
Okay, viral markers, agreed. Anything? No?
Alpha-fetoprotein levels, because HCC is also one of our differential.
Okay, agreed. Anything else? Finish? Do you want to do more?
The most important investigation. We are in doubt, no? Intrahepatic or extrahepatic. So what will you ask for?
Imaging then.
What imaging?
Ultrasound abdomen would be my first choice.
What will you look for?
First, I would look for because extrahepatic biliary tree, if any obstruction is there or any
What is the classic sign of extrahepatic biliary obstruction on ultrasound?
central intrahepatic biliary radical
Why
dilatation.
you are looking at intrahepatic biliary dilatation when your block is extrahepatic?
Because of back pressure, even the CBD, common extrahepatic CBD will be dilated as well as central IHBRD will also be there.
Okay, the usual reason is that extrahepatic can be obstructed at any point and the dilatation may not be visible. It may be obscured by gas, etc. But generally, IHBRD is easy to pick up this because there's a background of liver, and through the intercostal space and the subcostal area, you can easily diagnose IHBRD, where visualization of CBD, even if it is dilated, may be difficult sometimes due to gas and other technical factors. Okay. There are so many things which can be found out on ultrasound. Due to lack of time, perhaps you will not ask. But still, can you enumerate what all observation you should make when you do an ultrasound in a patient with a cholestatic jaundice?
First, look at the size of the liver.
Okay.
Echogenicity and borders of the liver or any nodularity. And look for, if at all CBD is visualized, look for diameter of the CBD.
Look for IHBRD. Then inside the liver, anything else?
Any hypoechoic lesions.
Look for any focal issue. You are telling FCC and all, no? FCC and cholangiocarcinoma. So look for any lesions. Okay. Then you come down and then look for, try to delineate CBD and CHD. Okay. Then
And the
next.
gallbladder.
Gallbladder.
And
then
pancreatic duct.
Pancreas, head of pancreas, pancreatic duct, then lymph nodes. Lymph nodes in the porta and the upper abdomen. Okay. Then the venous system, portal venous system, splenic vein, spleen.
Switch on the Doppler and look for the
flow.
Portal venous system and the hepatic artery.
Then look for ascites also.
Okay. You can move on.
Okay.
Next slide.
Okay.
Next slide. Okay. So we had some of the. Okay. Come to the labs. Yeah.
Hemoglobin is 13.5 normal. Total count is also normal. Platelet also 3 lakhs normal. Anti-HEV IgM is reactive. Other viral markers of A, B, C are negative. And progression of LFT from within a gap of 4 days. Initially, it's 6 and 4.6 of direct. And it's almost stands same after 4 days. ALT and AST is 91-84, which shows slight improvement within the next 4 days. Predominant ALP and GGT elevation for 447 and 1200, which is reduced to almost 50% after 4 days. And globulin is 3.8 and 3.5, which is almost normal, but there's a decreasing trend in albumin after 4 days.
What's your interpretation now? What are we dealing with?
Acute viral hepatitis may be in the cholestatic phase.
Yeah, exactly. That's what we also consider, because HEV instantly came as positive. Okay. So maybe he's had the jaundice, which was severe then, and now it's in the cholestatic phase. Okay. And alpha's gamma GT is sky high. So again, the gamma GT is so many folds high. So you cannot rule out the possibility of an extrahepatic biliary obstruction. You cannot be 100% sure that you're, it's still 880. Gamma GT is 880 and alphas is 320. So can we just leave the patient alone, or what should we do?
Should go for imaging.
The AST, okay, answer that question and then I'll ask the next question. Alphas is very much elevated. The GGT is very much elevated. Now you should not exclude extrahepatic totally. Now the SGOT, SGP, the AST, ALT seems to be very slightly elevated. How do you explain that if you consider acute hepatitis?
HEV, yeah.
How do you explain that? And your diagnosis is acute hepatitis with acute hepatitis, no?
Resolving acute hepatitis.
Yeah, he has evolved, not completely resolved. Going into the cholestasis, most of the patient actually the transaminase level tend to fall and alphas tend to increase. Okay, so by the time when they have classic cholestatic symptoms, very often the elevation of transaminases will be only minor. Okay, and create diagnostic difficulty. Here, of course, IgM HEV is positive, so we are much more definite. But otherwise, there may be confusions.
Yeah.
Can we go to the next slide?
Just 1 second. So this case is actually the surgical team. Okay. So then they asked us, why is the bilirubin not falling? What's your comment on that? It is static at 6. What's your comment?
Usually bilirubin takes time even and transaminase.
That's one. Any other possibility? Can it be there's a congenital hyperbilirubinemia in this patient? You have to consider the possibility. All the other things are settling, but the bilirubin is static. Okay. So what do you want to do now next?
Suppose you are given this lefty and asked to make congenital hyperbilirubinemia diagnosis. Will you make
Will you make that as a diagnosis? What will be the finding in say Dubin-Johnson versus Gilbert? What will be the LFT?
Indirect
what will be the total bilirubin and conjugated in Gilbert syndrome? What is the classic finding of a Gilbert syndrome on a liver chemistry? Rajendra.
Bilirubin will be less.
Bilirubin will be elevated. That is why we call hyperbilirubinemia. But when you look at the liver, okay, Rajendra.
Indirect hyperbilirubinemia with normal ALT, AST.
Okay, indirect hyperbilirubinemia is usually normal ALT, AST, and normal alk phos and other functions. But nowadays we have a confusion because most of the people have NAFLD, but some people taking alcohol, and therefore nowadays we have a combination where will be indirect hyperbilirubinemia with a mildly elevated transaminase and fatty liver. So one part, so the pure Gilbert's disease probably we are not seeing nowadays. Gilbert syndrome, we are giving a combination of fatty liver plus but there is a rule. In a Gilbert syndrome, the total bilirubin will not exceed 5 milligram. If the total bilirubin exceeds 5 milligram, you have to look for another cause, additional cause. Agreed?
Yes.
So it is more than 6. So you have to look for an additional cause, even if there is suppose it is hyperbilirubinemia earlier diagnosed. Which category you will try to put it? Gilbert's, Dubin-Johnson. What's the type of hyperbilirubinemia here, Rajendra?
Direct hyperbilirubinemia.
Direct hyperbilirubinemia. So which one will consider, Gilbert or Dubin-Johnson?
Dubin-Johnson.
Okay, this is a theoretical. This is not a Dubin-Johnson at all. We were trying to see your analytical skills. The moment you find an LFT, you must be able to spot this. Okay.
What will be the urine in Dubin-Johnson?
Sorry.
What will be the urine in Dubin-Johnson? What will be positive? All this you should know. It should be on your tip of your fingers. Bilirubin will be positive. Bilirubin will be positive. Okay, this is just an offshoot question. This was asked by the surgeons. So then we were discussing whether his overlying is got HEV. Supposing the HEV resolves and the bilirubin remains high, we will consider the possibility of a congenital. That's much, much later, nothing now.
What is the most common way by which Gilbert syndrome is diagnosed in the community? How often the patient comes to you with the Gilbert syndrome? What is the symptom? The person usually comes for something else. He goes to the hospital for something else and get the LFT done and find it out. That is because now executive checkup and all is done left and right. In olden days, it was acute viral hepatitis and then they check the LFT frequently. Okay, even without our advice and find the bilirubin is not improving. Then they can come with a lot of anxiety. And then we tell them, okay, this is unconjugated predominantly. So an acute viral hepatitis is in fact, Sheila Sherlock's books even say, is perhaps the point by which Gilbert is unmasked for the first time.
Exactly. That's what I said.
The word exactly Sheila Sherlock uses, unmasking of Gilbert syndrome. Now, we did not actually consider one important form of congenital hyperbilirubinemia, Crigler-Najjar syndrome. Why we did not consider that? Kiran Mai?
Age group, sir, because
age. So what are the two types and what are the type of presentation?
Type 1 and type 2, sir.
Type 1 will not see
it will be
the world for a long period. What about type 2? Again, presenting in the adult is very unusual. It's a much more serious and severe condition. No, it would have presented during childhood itself and will not last long. except very few cases. So that's why we did not consider Gilbert earlier because it's a very serious problem. It should have been diagnosed much earlier. Gilbert and Dubin Johnson are the one which come clinically, of which I would say 90% may be Gilbert, and very occasionally we find Dubin Johnson. And what is rotors, by the way?
Where is
Rotors
the defect in rotors?
have you heard of one rotor syndrome?
Where is
See,
the defect?
I am telling you all from our MBBS textbooks only. Your Davidson gives it all in great detail.
MRP2 gene mutation which causes secretion of the bilirubin into kinetic place.
Where is the defect in rotor? You're going in the wrong direction. Rotor is what? Uptake. OAT1B1.
Or
Rotor
I think
is
all of
import.
you should read the bilirubin uptake and excretion, bile salt uptake and excretion today itself before you sleep, because then only it will stick with you. Okay.
OAT1B1 is uptake in rotor. Exit is MRP2 for Dubin Johnson and UGT1A1 for Gilbert's and Krigler-Najjar. This basic you should know. Can we move on?
Okay.
Next. Just move on. Next. Yeah, so these were the tumor markers. Okay. So again, we were in a soup.
How will you interpret this, Sai Kiran?
577, which is very high. Usually, if you are considering intrahepatic cholangiocarcinoma, it will be a cutoff of 135 around. So 577 is very high, but it is coming down by 255.
Can it be abnormal in cholestasis?
Yes, sir. Not only the malignant conditions, but benign cholestatic conditions can also be cause elevation in CA99. So with the improvement in cholestasis, CA99 is also coming.
You have to keep your options open because it's a very high value. It's coming down. So if it's serially serial testing shows that it's coming normally or not becoming normal, it's okay. But otherwise, you have to keep an open mind about this high value.
Finding. Next slide. So nothing much on side-wing endoscopy. Ampullars normal endoscopy shows.
Which is a situation where you take a biopsy from the ampulla and make a diagnosis. What are the situations?
In the same context of biliary obstruction.
One ampullary carcinoma,
agreed.
duodenal wall malignancy.
Anything in that region, we will take biopsy. I am specifically asking ampullary biopsy.
Yep.
So periambulary carcinoma, okay, agreed. You take ampullary biopsy. Okay.
Any autoimmune disorder?
Autoimmune. IgG for cholangitis. This is one of the easiest method to take ampullary biopsy. It will and then look for IgG for cells. Okay. Okay. Next is this is.
The liver was normal, gallbladder normal, everything is normal. So no evidence of extrapapillary obstruction.
No IHBRD.
Next slide.
This is
so they went in for an MRCP. Okay, just to confirm and be 100% sure. So MRCP was also normal.
So what does it look like?
So in the exam we asked, so the candidate could not pick up the gallbladder. Okay, and you can't point out if some Rajendra, you can point out who's hosting it.
I
am doing it. What do you want me to show?
No, just ask him what is this? What is this?
Okay, what is this?
A tortuous cystic duct with gallbladder.
What is this? What is this?
It is common bile duct.
What is this?
Pancreatic duct.
So this is pancreatic duct, the thinner one. The bigger one is the bile duct. This is the area where it joins, and this is actually
common hepatic duct with intrahepatic radicals.
Okay, what is actually this?
Where is the cystic duct? Where can show the cystic duct?
They won't be able.
The tortuous in the first picture, the one which is going tortuous.
Yeah, this is it, no? Okay. So, but do you find anything wrong?
No, sir. I couldn't grossly see anything.
There is no obstruction at hilar level. There is no gross. Obviously, there is nothing, no stones or anything in the bile duct. There is no hilar obstruction.
So now what should we do with the patient? What should you do with the patient? Everything is normal. I think they had some gallstones, okay? Even the MRCP shows
Yeah,
the
a few
gallstones.
gallstones are there. CBD is 7 millimeter, but 7 millimeter is not that
Nothing.
much abnormal.
It's not that.
Okay.
So MRCP is normal. Now we were asked to come at this stage to what should be my opinion? What should I do? We were called at this stage by the surgical team. So what should I do?
I think I would wait.
Exactly. We'll wait. Exactly. Because things are settling. So just ask for a repeat LFT after 2 weeks or so and just see whether things are settling, because he's also settling. Jaundice is very mild, alkaline phosphatase, everything is settling. Wait for 2 weeks and then take a call as to what it is. Okay. And ask him to have a normal diet. I would really not go plunging for a liver biopsy at this stage. There's of no use. No. And HAV can present with this long cholestatic jaundice. So as of now, what we've done is just give him supportive treatment, asked him to eat well and have a normal diet, and just to come back after 10 days with a liver function test. So the bottom, what are the learning points in this case? The learning points are that you have symptoms all suggestive of extrahepatic biliary obstruction, but there are some points to say it could be intrahepatic as well. As Dr. VT mentioned, biliary should be included as one of the important differentials in this case. Viral hepatitis will come as an important DD. Wilson will be out. Autoimmune will be out. So you're left only with, there are only 4 conditions actually: alcohol, biliary, then you have the viral hepatitis as the 3 major causes. In that, you will have to shortlist. Okay.
Why don't we consider Wilson in this patient? Rajendra?
His age, sir. Second,
What is
age
wrong with
and
the
then,
age? What's the problem with the age?
32.
You have to be much more, pardon? Presenting for the first time at this age is extremely unusual. They would have presented much earlier. Okay. There's a general statement given in our books. If somebody presents after 50 with jaundice, you should not consider Wilson. But there are some reports between 50 and 60 also they can present. But after 60, probably considering the first presentation of Wilson after the age of 60 would be far-fetched. So we should not diagnose it. That is your explanation is the standard explanation. Okay.
Meeting, we have 10 minutes. Can we just take up quickly the...
Yeah.
It's a short case.
So who will discuss?
We'll ask Rajendra to take over. Go to the first slide.
Start reading, Rajendra.
First slide. Quick one. I think we'll go. Okay, I'll just tell you very briefly. She came with history of abdominal pain suggestive of NSA-related gastropathy. Okay, and incidentally, we had some findings. And there's a history in 2019, almost 3 years back, that she had a bleed and she had a banding. So we have some information. Next slide. So this is the finding. She has a spleen which is about 10 centimeters below the costal margin, and she's got a hepatomegaly. Now tell what are your differentials in this patient. It is a splenohepatomegaly. Spleen is predominant and liver is just about 3 to 5 centimeters, and this is about 18 centimeters.
Large spleen.
Large spleen, massive spleen with a moderate hepatomegaly.
Large spleen with moderate hepatomegaly. List of DD.
Quick, all 3 of you can take one. There's Dino is gone, huh? Dino is left.
Dino, are you there?
Yes, sir.
Okay, now it's your chance. DD of moderate hepatomegaly and large spleen. When do you call it massive?
When it crosses the umbilicus.
Okay, this is short of umbilicus. So this is large.
No, actually, the figure is a bit wrong. It goes up to the umbilicus.
Is it? Up to the umbilicus. Oh, okay, massive.
But it's more of a vertical. Okay, it's vertical.
First.
What determines the direction of enlargement of a spleen?
The splenic axis.
No.
Towards umbilicus, right left. Towards right left.
What determines the direction of splenic enlargement? Horizontal, right iliac fossa, vertical. The answer is phrenicocholic ligament. It's a phrenicocholic ligament that determines the direction of enlargement. Okay, more tight it is, it will become horizontal. Suddenly you'll find a spleen in the umbilicus, in the epigastrium. More lax it is, it drops down. When it is adequate, it goes to the right iliac fossa. This is a Viva question. All right. Now tell us what's the differentials for a massive splenomegaly with a moderate hepatomegaly. There's a history of EVL. Leave that aside.
Okay,
Quickly.
massive spleen.
Massive spleen.
No.
Just have the DDs
Just
for
tell
massive
1, 2, 3, 4. Massive spleen.
Classify
Massive
and
spleen
tell.
and gastroenterology illness. Which are the ones?
This
Chronic
can be a
myeloproliferative.
ward round case, okay? Ward round the bedside. This is the
Okay,
classical.
Rajendra.
Chronic myeloproliferative disorders.
Okay. Which one you have kept in mind? CML. Okay,
CML.
agreed.
Come on, list the hematological causes of a massive spleen. Hematological causes.
The
Each
most
one
important are hematological ones. So list out hematology first. One is chronic myeloid leukemia. Sai, myelofibrosis. Agreed. Third,
Hemolytic anemia.
Please don't answer on the chat box. Yeah.
what?
What is the
Hemolytic
causes?
anemia. Sir.
Hemolytic.
Massive spleen.
This much
Just
big
tell.
spleen is unusual.
RBC lineage, what is it? Massive spleen. Polycythemia. And platelet?
Essential thrombocytosis.
Thrombocyte. That's how you answer. Then leukocyte, you have the CML. So we have at least 3 here. Then hairy cell leukemia. These are all the ones that can cause massive spleen hematological MPNs.
Infections.
What about myelofibrosis?
Yeah, that she has already told, no? Myelofibrosis.
Then next.
There, I think we have completed the hematology part. I think infections.
Common infections.
Malaria.
Okay.
Leishmaniasis.
Kala-azar. Yes.
Kala-azar.
Good.
Okay.
Then
any condition pertaining to gastroenterology or hepatology?
Parasite. Any other parasite? You can get hydatidosis. You can get in splenic abscess. You can get in cystosomiasis. Can it be cystosomiasis? What's the presentation of cystosomiasis?
In which part of the world cystosomiasis is seen?
North America.
Sub-Saharan Africa.
Egypt.
Okay.
Egypt. Yeah.
Egypt and those regions. Okay.
But how does cystosomiasis cause splenomegaly? What does it cause?
What type of portal?
No, that they don't know. Where does it reside, cystosome?
Sign, please.
They'll ask you, doctor. They'll ask you.
Pre-sinusoidal.
I can't hear you.
Pre-sinusoidal.
Pre-sinusoidal, intrahepatic, pre-sinusoidal. Yeah, exactly. So it can present as NCIPH. No?
NCIPH.
Yeah. So you must know certain things. Life cycle. Adult sperm lives there, then it goes down. It contains japonicum, hematobium. All these 3 types are there. So you can get one of the largest spleens you get is in cystosomiasis. Okay, so hydatidosis, cystosomiasis, splenic abscess, then you have your malaria and Kala-azar. Now, what about the infiltrative disorders?
Amyloidosis.
Amyloidosis, very good. Then sarcoidosis, yes. Then storage disorders, for glycogen storage type 4. Can get in
pediatric practice, yeah.
You can get in
sphingomyelinosis, okay.
So in a patient with GI bleed with this, what is the possibility, likelihood of?
Non-cirrhotic portal fibrosis.
Non-cirrhotic intrahepatic portal hypertension. Okay, next slide. How will you investigate this patient? How should we investigate this patient now? Patient has come after 3 years and she's come actually with pain, but amylase was normal. She's got a massive spleen. She's got a moderate hepatomegaly. What should I do? Levels of investigation. I have to assess the patient. So what investigation should I do? I've been called to see the case. As a consultant, you're asked to see the case. What would you ask?
Liver function test to look for age reversal.
Will liver function test be the level 1 investigation of this patient with a massive spleen?
You are all telling about hematology as a DD, no?
Complete blood count to look for hypersplenism.
Not hypersplenism. You may get thrombocytosis. You can land up with something else. So CBC and peripheral smear is the level 1 investigation of patient with massive spleen. LFT is likely to be normal. Patient has got nothing there. No? So what level 1 is? A good detailed peripheral smear along with a complete blood count. That's a level 1 investigation. What would be the level 2? What will be the level 2? What's the level 2 investigation? LFT, why should you keep on harping on? It's a hematological case, no? It can be just hematological. Would you ask for a liver function test if this patient has a level 2? Ultrasound, no? Ultrasound with Doppler will immediately stratify it is predominantly liver disease or it's predominantly a hematological disorder. Okay, so look at this. The portal vein is hugely dilated. It's about nearly 2.1 centimeter. And then you look at the indices. What is hepatofetal and what is hepatoflugal?
Hepatopetal towards the liver, a portal vein flow, blood flow towards the hilum.
Is called?
That is hepatopetal. Towards the hilum is hepatopetal.
Hepatopetal. When can it become flugal? When can portal vein flow be hepatoflugal?
When significant fibrosis enough to cause
or
portal vein thrombosis.
backflow.
Portal vein thrombosis will again be onward. When can it be reversible? When there's outflow tract obstruction, no? Outflow tract obstruction, we get a reversal. It's not going onwards, you can get a reversal. And look at the flow, it's only monophasic. So what are the investigations? Can we go to the investigations?
I will just ask you, why the flow actually reverses? And can anyone answer? What exactly is the reason for the reversal of the flow? Suppose you have a blocked system, the blood will not flow. Okay, if your pipe is blocked, the water will not go. But how can the have a reversal of flow from the pipe if there is an obstruction? Have you ever thought that way? It is actually arterialization of the sinusoids, and actually hepatic artery also supplies a lot of blood. The portal vein is actually technically blocked and the blood comes reverse in the reverse direction. The sinusoids all get arterialized. I think you have to read a lot about that. Okay, now we will concentrate on the next investigation. So this is, what is this?
VT, just can you go to the differentials? Just go back. This one. So they just helped you with the slide. So you have the myeloneoplastic will come as number 1, hematological, lymphoproliferative disorders, then infections we have highlighted, and infiltrative disorders. So these are some of the causes of have this as a splenohepatomegaly. Okay, these are all causes of massive spleen. Okay, now, so this is the patient never had a CT, no? So I asked for a CT abdomen. One of you can just take up the discussion on this and just say, what is that? What sir is pointing?
Clean.
What phase is number 1? What phase is the left top one?
Arterial.
Why do you say it's arterial?
The aorta is very thin.
What else tells you it could be arterial? All the vessels are thinned out. Arterial supplies always, artery supplies 80% oxygen, but only 20% blood. So arteries will always be thinned out. Okay, that is the first one. What else is glaring in the first picture? First left top. What view is it?
Axial view.
Axial view. Okay. So what is it? What is the one that is seen? Can you just describe it?
Massive.
Go to the right. Go to the right one. Right top. Yeah. What are the things you see? What view is it? What is
this structure? Is it gallbladder? Is it? Will gallbladder be visualized in the like this? This is a vascular structure, no, with a lot of contrast.
Portal vein.
But why does it look like a sac? So when your portal vein look like a bag, what is the diagnosis? What type of dilatation is called that? When portal vein bulges?
Fusiform dilatation.
Aneurysmal.
Aneurysmal dilatation. No?
Aneurysmal dilatation.
What view is this?
Sagittal view.
Sagittal view. And what is happening to the left? Dr. VT just asked which is the right and left. Which is the right branch? Which is the left branch? What is that? What is that? Which branch is it? I know, I'll tell you. One candidate failed because he or she could not identify the gallbladder on the CT, could not identify the vessels on the CT, And I think at this juncture, there's no reason why you people should not be able. You have to pinpoint and read more and more of this. Now, can you tell that what is search showing?
What the examiners are assessing is whether you have worked properly in the ward, whether you have routinely read CT and etc. Okay, we are not considering you as going to be future radiologists, but when a film is given to you, you must be able to understand even that. Okay.
So what is happening? Can you just search pointing out something here?
Right branch of the portal vein on the top.
No, arrow is which one? No, where is this arrow? No, that arrow, where is it? Right or left?
Arrow.
Yeah, so he's got the pointer there. Dr. VT, can you show the pointer there?
Yeah, the pointer is.
There it is. Yeah, that pointer. Which branch is it?
That is left.
Pointer disappears.
But it's there. You can show it. You have to know which is right and left branch.
This is left branch. Watch.
This is left. It's just the opposite. That's the right branch.
This is the right lobe, no?
That's the right lobe.
This is the left lobe, approximately. So this is the right one. And this is the leftis aneurysmal and tortuous.
And what is it common to see the portal vein like this within the liver?
No.
What is a normal division of the portal vein? What is a normal division? How do you describe it? Dichotomous, no? You go dichotomously and go right up to the periphery. But here, the vein is seen almost to the periphery. And what is it that you're seeing right on top near the diaphragm? What is happening there? The hepatic venules that is communicating with the hepatic vein. There's a communication. It
hepatoportal shunt.
It is not hepatoportal shunt. It's a portal to hepatic vein shunt. And you can see it beautifully on the left side, the left lower corner.
Normally, it is like a branches of a tree. So we are not seeing branches here, but we are seeing a big trunk, which actually goes and hits at the hepatic vein.
So what will be the presentation of this patient? What will be the common presentation of this patient?
What is that known as when there is a huge communication between portal vein and the hepatic vein? What is that called as?
You started it. What is it?
If it is congenital.
It is congenital. So it is intrahepatic portosystemic shunt. It's intrahepatic portosystemic shunt. Okay. And okay, next slide. I've just got one or two slides on that. So there's an abnormal vascular communication segment A between portal vein and hepatic vein. And portal vein suggests for intrahepatic portal vein is shunt. Main portal vein, look at that, 2.2 centimeters. Splenic vein is 2.4. Superior mesenteric vein is 2.2. So this is a type of forward flow portal hypertension. So there's increased flow causing huge dilatation and is draining into. So what will be the clinical presentation? Chronic HE. See, you should know immediately what's happening. This is type of Abernethy, Abernethy syndrome where we have, it's more to the IVC. So I'll just show you 3 slides on that. Next slide. Next slide. So intrahepatic malformations can be intrahepatic. What you saw now is intrahepatic portosystemic shunt. Abernethy is what is between the portal ductus venosus communicating with the IVC. And then we also have what's called as umbilical systemic shunt. Umbilical vein that drains to the left branch of portal vein can also drain into the systemic circulation. Umbilical vein is portal or it's systemic?
Systemic.
Umbilical vein is systemic. So after you finish whole thing, Ramayanam, and then we come to this. Umbilical vein is systemic. Where does it drain? Left branch?
Left branch of the portal vein.
So it is portal system or systemic system?
Portal
system. So this is Abernethy. Okay, you have all these. Basically, in Abernethy, it is to the IVC. Okay, portal vein to the IVC. Next slide. That's all will be available now on your umbilical. This is something that we did in the drills. We had one interesting case. Next slide. Next slide. So this is umbilical vein. Look at this. So we had a patient where the left branch of the umbilical vein was communicating with the iliac vein, common iliac vein. So the blood was flowing in the portal vein, umbilical vein, and then draining into the IVC. It was and the patient presented as chronic HE. They'll all be chronic, and that lady was presenting like schizophrenia. It was the ammonia that gave us a clue. So the question is this, I asked this question also in the exam. What are the causes of isolated hyperammonemia? Can you just tell now? Isolated hyperammonemia with a normal liver function test.
Urea cycle.
Very good. Urea cycle defect, that is OCT, ornithine transcarbamylase, OTC deficiency. Very good. Number one. Number two, patent ductus stenosis. Number two, then you have this congenital umbilical vein shunts, and the last is intrahepatic photosystemic shunts. In all this, the liver is normal. Okay, but you have these shunts. So I just thought just to tell you that this is not the examination point of view. I'm just telling you, these are things that you come across in your day-to-day practice. If ammonia is high, isolated hyperammonemia, you have to consider these 4 possibilities. All right. Okay, I think
whenever you have a cirrhotic patient who has not, and the decompensation is the hepatic encephalopathy is out of proportion to other liver function deterioration, I think you have to suspect the additional presence of a shunt. Okay. Addition, yeah, because otherwise everything should go parallel. But just encephalopathy is out of proportion, and rest of the functions are fairly normal. Then you have to think of this possibility.
Bypass A, B, C, D, A, acute liver failure, B is bypass, C is cirrhosis, and D is come as ornithine transcarbamylase deficiency, urea cycle. When you discuss hepatic encephalopathy, you have A, B, C, D, I hope you know that. Yeah. A is ALF, B is bypass, C is cirrhosis, and D is the ornithine transcarbamylase deficiency.
Urea cycle abnormalities.
Urea cycle abnormalities.
That can come as an exam question. Urea cycle abnormalities. Okay, isolated hyperammonemia. Anything can happen.
Now you can ask any questions you have, any doubts, anything that you would like to discuss. We take 2-3 minutes.
There are seven in the chat.
Is there any connection between the umbilical system, whatever we saw, intrahepatic shunt and hepatosplenomegaly?
What is it? Sorry, what did you ask?
Is there any connection between this intrahepatic hepatic shunt and hepatosplenomegaly, what we are seeing, or it's just an incidental finding?
This is an incidental finding. Ammonia, the thing is, you have to keep this patient on follow-up for only ammonia, because if she goes for chronic HE, she'll have problem with the brain. So we just told her once in a way, just keep checking the ammonia, see that you don't get constipated, and otherwise just be on a normal diet. Ammonia was normal in this patient, but anytime she has high ammonia, it is one of the causes of isolated hyperammonemia.
Somebody has asked about this. This is the aneurysmal dilatation of the branches of portal vein, and this is the left, and this is the one. This is the picture which shows a broad venous communication between the left branch of portal vein to this is possibly
the hepatic vein. Yeah, that's one. That's right. And I'll show them the lower one, left lower, that huge splenic vein and portal vein. Yeah, come down next to this. Yeah, there's a huge portal vein and splenic vein. And splenic vein.
Yeah. We'll come to the end of today's class. Anything else to as a take-home message?
Any questions you have? Any questions any of you have?
The three participants, do you have any questions?
Yeah, 3 of you, any questions you have? Any doubt? You're finding it very tough? Are you finding it okay?
Okay, we may be a little harsh on you because I believe that something which is developed in fire will not built in the sun. Okay, if you are grown in fire, you will not built in the sun. So consider examination is a place where a lot of heat is there. Okay, but you are already cured in fire, so you will not have problem. So your training, if it is made little tough, your examination will be made more comfortable. Okay, don't feel bad if we are little rash on you. We have nothing personal against you. We don't want to humiliate you at all. But when we find an answer which is not expected of you, it actually comes out of our mouth without much control. So kindly bear with us if we have we have affected your feelings at any time. But our intention is that you should all learn and get good marks. We have no bad intention to harm you, to make fun of you, to humiliate you, nothing. There was some doubt, there were some people having apprehension that both of us are a little harsh when you do online class, but we practically don't want to be harsh to anyone. Okay. Whenever you say a good answer, we actually enjoy it. And we want all of you to be excellent clinicians. Both of us are doing purely out of passion, and we don't get any benefit out of any of these things. Nobody is going to give us any award or money or anything. Both of us want to do this out of passion only. Okay, so we'll be happy if you people learn very well and appear for the examination with a lot of preparation. And we actually want all of you to pass. Okay. As teachers, we are happy when 10% of you passes. Okay, we are actually upset when a candidate fails. We are actually upset when a candidate does not answer properly. Okay, but the system actually demands that we cannot pass a candidate who does not answer properly. We cannot pass everyone. Then there is no need for examination. Okay. I hope we people, you understand us.
Please understand this.
Okay. Because there were some complaints that our training also is a bit harsh, etc., etc. But we want to make it sure
And
that
other thing is it's open house. You don't want to attend, don't attend. No problem. You feel we are harsh, you don't present. No problem. Those who
okay.
are able to face us, you present. Nothing. Even if one person comes, they're going to take a class. So it is just that we've started something and we just want to pursue it, just disseminating whatever we have learned and acquired.
The class is recorded, and I will get the link and will post in the clinics group. So if someone wants to download it and keep it with you for revision, it will be possible. I hope it will be possible because it has been already recorded and the record is going on. So it should be possible. So I will try to post the link also. I think
Yes,
it's time, no?
the
Jerry, are you there, Jerry?
1 minute, BT, does portal cystic shunt present with dilated veins or abdominal wall? It depends on the site of portal hypertension. There was one books to study. You read your basics Lessinger. Your basics Lessinger is your
For clinical
gastroenterology.
examination, Hutchison,
And Harrison.
Das, and of course, Harrison is good for approach to this,
Approach.
and
Very
finally
good.
Schlesinger.
Very good.
Okay, approach to symptoms.
We'll
Jerry is
conclude.
there? Okay, Jerry seems to be not there. So, on behalf of all of the faculty, on behalf of ISGK, I want to thank Jayanti ma'am for taking so much pains and finding out cases and calling up many people, arranging classes, everything. Okay, you will never get a teacher like Jayanti ma'am, and she is a very seasoned examiner also. She has been extremely kind to us by helping us to conduct these classes, and she's the most sought after faculty also. So we are proud that she is with us. And thank you, ma'am, from bottom of my heart for doing this job for the last many years, and hope the God will give you enough strength, courage, and health to continue with this. Okay, I thank all the participants who were courageous enough to come and present the cases, and you have done wonderfully well, and all others who have joined. And I thank Clarinet for having given this platform. And they are recording it, and thank you, Clarinet. And Dabolina, are you there? Okay, I think I can stop sharing, and with this
Thank you.
the session will be over, and I will end the session.
Thank you, Vicky. Good night.
Good night.
Thank you, ma'am. Thank you.
Thank you. Thank you.
Thank you.
Is anyone from Clarinet there, or I can stop the session?
Stop the session.